Welcome to the Richard and Leonora Hill Lecture Series for 2021, and it gives me great pleasure to introduce our speaker. Our speaker is Maureen Maguire, PhD. She is the Carolyn Jones Professor of Ophthalmology at the University of Pennsylvania with a secondary appointment in the Department of Biostatistics, Epidemiology, and Informatics. She received her doctoral degree from the Department of Biostatistics at Johns Hopkins Bloomberg School of Public Health. Dr. Maguire is an internationally known expert in the design and conduct of multi-center clinical research projects in ophthalmology, and she has directed coordinating centers for several national clinical trials. Her work has concentrated in the prevention and treatment of age-related macular degeneration. Other areas of research include preschool vision screening, dry eye disease, corneal transplantation, and diabetic retinopathy. Her connection specifically to Ohio State Optometry, besides this lecture today, is in the area of pediatric vision, and she worked for many years with our own distinguished professor, Dr. Maureen Culp, and Professor Emeritus, Dr. Paulette Schmidt. I believe Dr. Maguire has achieved the ultimate goal of patient-oriented research that many of us do, and that is to have a tangible, significant impact on how optometrists and ophthalmologists deliver vital eye care to their patients. And Dr. Maguire can certainly claim that achievement. She's a Gold Fellow, and I'm excited to say President-elect of the Association for Research in Vision and Ophthalmology, FARVO, and has received the Senior Achievement Award for Distinguished Service from the American Academy of Ophthalmology, the Singerman Award for Clinical Trials from the Macular Society, and the JDM Gass Award from the Retina Society. She served as a member of the editorial board of both Ophthalmology and Investigative Ophthalmology and Visual Science, among other journals, and has more than 300 peer-reviewed publications. This recognition of Dr. Maguire as the 7th Richard and Leonora Hill Lecturer during Women's History Month strikes me as particularly significant. Dr. Maguire has made history and continues to make history in her work to eradicate visual impairment. Now, for just a couple of logistics, as Dr. Maguire is speaking, please log your questions in the Q&A feature on Zoom, and I'll then moderate it and compile them for response at the end of the lecture. And as always, we welcome Dick and Lee Hill and thank them for their generosity in endowing this lecture series. Today, I issue a special greeting to the second Dr. Hill in the family, Cindy Hill, MD. Thank you for joining us. I definitely can hear everyone's collective applause as you join me in welcoming the 2021 Hill Lecturer, Dr. Maureen Maguire, to the Ohio State University College of Optometry. Maureen, we're all yours.
Great. Thank you so much. I'm just going to take 1 second to get share screen going. And do you see my first slide? Excellent. So I'm so excited to be giving this lecture tonight. I am thrilled to be selected as part of this lecture series, the Richard and Leonora Hill Lecture Series. I am so sorry I am not here to spend some time with you and with Dr. Cindy Hill. But perhaps another year we'll be able to do that. Whoops. As Carla mentioned, I have some ties to the School of Optometry. And going back some years while we were all at Johns Hopkins, Tom Rush and Roanne Flom and I worked on a few low vision projects together. So hello to some old friends there. And for the past 25 years, I've worked on the Vision and Preschoolers studies, a series of studies with superb leadership, first from Paulette Schmidt and currently from Maureen Culp. So hello to you too. I am sure that some of you, when you first heard that a biostatistician was talking, were quite afraid of what might be the content of such a lecture. You can relax. It's not going to be about mixed effect models that can accommodate both eyes. This is going to be probably a very different type of lecture than is usually given. And this is about the birth of the clinical trial and its aftermath, with some of the implications reaching 2021. I do have some disclosures to make. I have received payments from Genentech for service on data and safety monitoring committees. I will discuss off-label use of drugs, and I will refer to the brand names of some drugs rather than generics. So as an overview, the talk that I am going to give centers on age-related macular degeneration. So we'll spend just a few minutes on that. Talk a little bit about the treatment of neovascular AMD back in 2005 and how that led to the comparison of AMD treatment trials, the CATT trial, the study design, the hurdles we faced, the resolution of some of those hurdles, the results we produced, and the impact of those results. Also, I'll be talking about how public policy and healthcare policy has influenced the trial, and that will be interweaved throughout the talk. As most of you know, age-related macular degeneration is the leading cause of blindness in the United States and most Western countries. And what I want you to note, though, is this the orange bars, which shows the prevalence of AMD over time. And you can see that while we have a lot of AMD now, over the next 20, 30 years, the prevalence is going to increase dramatically. As you know, early AMD is characterized by drusen and pigmentary changes. Usually both eyes are affected, but vision is rarely worse than 20/40ths, and patients do have problems with night vision, color vision, and contrast sensitivity. With late AMD, there's two major forms: choroidal neovascularization, or as we now call it, neovascular AMD, and even more recently, macular neovascularization is the major cause of blindness from AMD, with geographic atrophy accounting for about a third of late AMD. I'm going to go back now in history to about 2005, a little earlier actually, when we did natural history studies in neovascular AMD. And the purpose of this slide is to show that at that point, the angiographic characterization of the neovascularization was quite important. And we had classic CMV, which was well demarcated, occult neovascularization, less well demarcated, can't quite tell where it starts and ends, and then a great number of mixed lesions. And the natural history from the presenting visual acuity to 5 years out, 60 months out, varied by the three types of CMV, but they all ended up in the same spot, which is a median visual acuity of around 23/20ths. So very poor vision. In 2005, there were three treatments available. There was thermal laser, and that was limited to about 20% of all lesions because the laser had to be aimed directly at the neovascularization. So the lesions needed to be well demarcated. We had Visudyne, or photodynamic therapy, with verteporfin, and that treatment was limited in its effectiveness to only eyes with predominantly classic neovascularization. In 2004, the first anti-VEGF agent, Macugen, was introduced, and that blocked only one of the forms of VEGF, and again, its effectiveness was limited to predominantly classic neovascularization. And here you can see for Macugen, the study results, where for the sham group, we see the standard for neovascular AMD, steady decline of vision with sham injection. Through 1 year, a loss of about 15 letters or 3 lines. Whereas the 3 Macugen groups at different dosages still had decline, but less steep. At that time, I was working with other collaborators at the University of Pennsylvania, Cleveland Clinic, and Duke University on the next clinical trial, what we thought would be the next clinical trial. And Macugen, while it had some effectiveness, was expensive at $1,000 per injection every 6 weeks. PDT was also expensive at $5,000 to $7,500 with about 3 treatments per year. And we were wondering, can we decrease the frequency, perhaps lower the costs by combination therapy? So in May 2005, we were working very hard on a grant to submit on June 1st for a trial of Macugen in combination therapy. However, that all changed. On May 23rd, just a week before the grant was due, there was a news release of the phase 3 Marina trial results on occult neovascularization. And there were 2 doses of the Lucentis and 1 sham injection. And the results that they showed were just astounding. Certainly, the sham group showed the same characteristic curve of steady loss of vision with an average loss of about 3 lines over 1 year, whereas the treated groups actually increased vision and maintained that increase in vision, so that by the end of 1 year, there was an average of about 20 letters difference in the 2 groups. And that is just a huge treatment effect. So this was fantastic news for patients with neovascular AMD. Soon thereafter was the second trial from Genentech for Lucentis, this time with predominantly classic lesions. And instead of a sham injection, the control group got PDT, the treatment that had shown some effectiveness. But again, the 2 Lucentis groups showed a huge difference, better than the control group, the PDT. So that was the end of the clinical trial that we planned to submit just 1 week later. It was clear to us that the future for treating AMD was going to be with the anti-VEGF agents, and in particular, Lucentis. However, the picture again changed just 6 weeks later at the annual meeting of the American Society of Retinal Surgeons. And that was where the Marina results were presented by Genentech representatives for the first time. So this was their great debut of actually showing the slide I just showed you. Following that, Dr. Phil Rosenfeld reported on 1 patient, not the 900 patients in the Marina trial, 1 patient who he had treated with intravitreal Avastin, bevacizumab. Now, Avastin is an anti-VEGF agent that had been approved for the treatment of colon cancer by intravenous administration. And it too had been made by Genentech. In fact, the 2 drugs, Lucentis and Avastin, were derived from the same molecule, but the Avastin was larger and thought to be so large as to not be able to penetrate the retina. And there had been a publication from Genentech showing that a similarly sized molecule did not penetrate the retina. Previously, Dr. Rosenfeld had treated some cases of people with neovascular AMD with intravenous Avastin, had good results, but there were concerns about the side effects of intravenous Avastin, namely strokes, and heart attacks. The effects that Dr. Rosenfeld showed were quite dramatic in that one patient. And it was amazing that between August and December of 2005, Lucentis went from being a drug that, Avastin went from being a drug that was used only for the worst cases, salvage cases, to actually being first-line therapy. Now, Avastin was not approved at all for treatment of AMD, only for cancer. But it was chemically similar to Lucentis. The dramatic results were apparent in the short term. It was inexpensive, about $50 per injection if you took a 4 milliliter vial and divided that up. And interestingly, Medicare and insurance carriers started covering Avastin almost immediately, along with the injection procedure. Now, the stop signs were that this was totally off-label use. The drug was applied for, approved for intravenous injection, not intravitreal. So the safety of this long-term or even short-term was unknown. And there was no controlled trials of short-term or long-term efficacy of Avastin. So there was widespread debate about the ethics of using Avastin off-label, untested, while people were waiting for Lucentis to be approved. It became apparent that Avastin had made a big inroad into the treatment of AMD, and that some sort of comparison of Avastin and Lucentis would be necessary. We needed to know more about that. So the same study group that had been preparing to do the combination therapy trial that was to be submitted in May, decided to switch gears and go ahead and develop a clinical trial to assess these treatments. And Dr. Dan Martin from the Cleveland Clinic, Stuart Fine from Penn, along with myself, and Hee-Xiong Ying, our senior biostatistician, Glenn Jaffe and Cindy Toth from Duke, and Juan Grunwald and Ebenezer Daniel from Penn at the Reading Center, and Dr. Marianne Redford as our project officer moved forward with the development of a trial. And the study that we designed was comparing a Lucentis and Avastin on a monthly injection schedule, as Lucentis was originally tested in the Anchor and Marina studies, and then also on a PRN or as needed schedule. When Avastin was first started to be used, people were concerned about the side effects, the possible side effects of this tiny dose causing systemic complication. So treatment with Avastin started off being as frequently as needed, and as needed was defined as basically having fluid in the retina. So the CATT study was designed to assess the two drugs and the two dosing regimens. And patients would be seen monthly for 2 years or 26 visits. And here you see a schematic of the CATT treatment where the two monthly groups receive an injection every single month. The two PRN groups receive an initial dose, and thereafter they were treated only if they had signs of fluid on OCT or other signs of active CNV like hemorrhage. At 1 year, there was a re-randomization to a different dosing strategy, but everybody stayed on the originally assigned drug. And I'm not going to go into the year 2 because of lack of time. So this CATT history now shows us that about 6 months after the results from Anchor Marina came out, we submitted a grant to the National Eye Institute. And the National Eye Institute saw that this was an important topic and gave expedited review. In June 2006, Council decided they would fund the CATT trial. And also at that same time, Lucentis received FDA approval for the treatment of CNV. And the cost was not $1,000 similar to Macugen, but the cost was $2,000 per dose. And remember, the approved treatment was 13 times a year. When we received the news that our grant was funded, we were delighted, but not everyone was delighted. And here are some of the reactions from Genentech and the pharmaceutical industry with regard to the CATT trial. And I'm going to read them just because I think they're important. CATT opens a Pandora's box for the drug industry by taking testing out of the hands of the companies, changing the rules of development, and potentially undermining a blockbuster long before it becomes off patent. CATT is one of the top 7 harbingers of change, likely to affect the evolution of the pharmaceutical sector. If CATT shows Avastin to be as similar and effective for AMD as Lucentis, it may pave the way for an increasing number of payers to take comparative drug studies out of the hands of the pharmaceutical companies. And CATT may create a disincentive for companies to study such areas, leading to unintended consequences. Little did we know that we were going to have such a large influence. We just wanted to do our comparison trial of dosing in drugs. So how did this, so what? What kind of influence why did it matter if the pharmaceutical industry was interested in CATT? So let's go through some of the activities to see how that interest may have influenced our study design. When we designed CATT in January of 2005, or 2006, we assumed that Lucentis would be approved by the FDA in June 2006 and would be covered by Medicare as an FDA-approved drug. Also, when we wrote the grant, we assumed that the NEI would pay for the Avastin and for the repackaging of it from the 4 milliliter vials into the much smaller 0.05 millimeter vials that were needed for intraocular injection. We knew that 95% of AMD patients were covered by Medicare or Medicaid. And we had actually had talks with CMS that handles Medicare starting in November of 2005, before we entered or submitted the grant. We had anticipated that Lucentis would cost about the same as Macugen, as I said earlier, $1,000 a dose. And with that estimation, we saw that the cost to Medicare for Lucentis alone would be at least $2 billion per year. We thought CMS would be very interested in our study, and indeed, in November, they said they were very interested, but they didn't approve science, and that any further discussion would be contingent on NIH approval. So once we got our go signal from the NEI in June of 2006, we immediately set up a meeting with NEI, our leadership, with the CMS officials. And the basic outline that we showed to them was that if you took the 1,200 patients that we intended to enroll into the CATT study and treated them as in the original trials, those 1,200 patients would cost CMS $50 million. If those same 1,200 patients were enrolled in CATT, the cost to CMS would be about $25 million, because half the patients would be treated with Avastin that was being paid for by the National Eye Institute. so that the savings would be $25 million to CMS if they, for our trial. So we were interested in whether CMS would be willing to help us with the trial, perhaps by paying 100% rather than the usual 80% for the Lucentis. Could they help us with costs for repackaging the Avastin? Could they help us with some of the drug distribution costs? All of these costs are ones that are usually borne by the pharmaceutical company when they are sponsoring a trial, even when it's in collaboration with NIH. And the response was that they were very enthusiastic about the trial, but CMS pays bills and it doesn't do research. And what they also said was the current CMS policy appears to prohibit payment of Lucentis in CATT. Now, we were surprised by that. We understood that Avastin, off-label use, would not be paid by CMS. But Lucentis was FDA approved and was being paid for by Medicare. So how could this be? And what the CMS officials pointed to was the 2000 Clinton clinical trial policy. The intent of that policy was to open clinical trials to Medicare beneficiaries. Prior to that, many people, if they took Medicare, could not get payment for any of their treatments if they were in a clinical trial for that cause. And in that clinical trial policy, the CMS lawyers highlighted that Medicare covers the costs of the routine costs of qualifying clinical trials, except for the investigational item or service itself. And their point was that Lucentis was under investigation, and therefore it was the investigational item. We kept pointing to other language in the policy that said routine costs in clinical trials include items or services that are typically provided absent a clinical trial or conventional care, as Lucentis was being paid for by Medicare for anyone outside of the clinical trial. The CMS officials told us that we had three options for moving forward with CATT. One was an act of Congress. The Medicare policy was about to be revised, scheduled for revision in the summer of 2007. And in that, there was a plan to explicitly state that coverage was allowed for treatments otherwise covered by Medicare. But we said, that's a year from now. That's really too long to wait. Another option was a program that CMS had of coverage with evidence development. And this was a program that they had to see if there could be extend national coverage to a particular service or treatment. And the primary purpose was to get additional evidence for CMS to make payment determination. But they said Lucentis had already undergone the major groundbreaking clinical trials, and actually Avastin was already being paid for by CMS, so there was no reason to make a determination for payment. So we couldn't go through that route. That left us with the demonstration project route for looking at different payment mechanisms to get the Lucentis paid for, but we were warned that very few had ever been approved. In addition to the cost of Lucentis, we had other challenges to overcome. Even if Medicare paid for the Lucentis, there were co-pays that the patient would be responsible for, that other 20%. And that would be $400 per injection for Lucentis and $10 per injection for Avastin. Many patients would not, we thought, many patients would not agree to randomization under those circumstances, and that patients randomized to Lucentis might switch over after having been subjected to the billing of $400 per injection for several months. Also, there was the issue of masking, since the explanation of benefits would state what drug was being provided. We also needed to have a central drug distribution center so that we could repackage the Avastin in following good manufacturing processes. And it would be ideal if we provided the Lucentis and the Avastin to our clinical centers similarly. There were also some little lesser hurdles, but hurdles nonetheless. One was that we wanted to have our drugs masked. That was important to us. And so one was to make the Lucentis vial look like an Avastin vial of the drug. So what we thought we could do with the help of our investigational drug service is to cover the label of the Lucentis bottle. The top has, I don't know if you can see, but there's a little DNA symbol on the top. That could be replaced without breaking the sterility. That could be replaced with a standard cap. And then there is the DNA tattoo that's on top of the vial. And our pharmacist thought that could be covered with foil. So we thought, well, we'll be able to at least mask the drug, but not so fast. Lucentis did have a special custom sealer. And you can see that this is clear glass and this has the silver colored sealer. And we actually found the manufacturer who made that sealer and said, could you make that for us? The manufacturer said, yes. The contract that they had with Genentech did not preclude them from making it and selling it from anybody else, but they were unwilling to risk the business losing Genentech as a client, so that they would not provide us with those sealers. But back to trying to get the Lucentis paid for. We tried many, many different plans under this demonstration project. We had plans where CMS would purchase all the drugs before the start of the trial, and that's similar to an industry donation. We had plans where Penn would buy all the drugs, patients would pay Medicare, Medicare would pay Penn. There was one where we would do all the billing at the coordinating center to one carrier. There are many Medicare carriers, about 15 across the United States. We would have Dr. Fine as the MD, and that one carrier would pay us. We talked about having the CMS computers reprogrammed so that the explanation of benefits did not list the drug. We enlisted the help of a lot of people to try to help us in moving forward with these projects. We had meetings, correspondence with the CMS acting director, Leslie Norwalk, the director of NIH at the time, Elias Zerhouni, the ophthalmology professional organizations like AAO, American Academy of Ophthalmology, have lobbyists. They were lobbying for us. Some of our ophthalmologists took care of congressmen and senators, tried to exert influence that way, even through some high-level contacts in the White House. But despite many, many different plans, over the course of about 9 months, all plans were ultimately deemed as not feasible or illegal by either the CMS lawyers, or if the CMS lawyers thought that the plan was legal, that was vetoed by the Office of the General Counsel. Excuse me, whoops. All right, sorry about that. So we were nearing the 1 year mark from our meeting with CMS and coming up on the 2007 revision of the CMS Medicare Act. And we were surprised at FARVO that Genentech leaders requested a meeting with Dan Martin, Stuart Fine, and myself in which they told us that some of the leaders in Genentech thought that helping CATT would be the best strategy, and that they were willing to supply both drugs in mask vials free of charge. And we were just thrilled. And we got to the point of actually talking about the date of a drug fill and the logistics of the supplies. We went to our DSMC, said, this is our latest plan. They approved it. We set up a training meeting for the end of September. But then in July, the Genentech board decided not to supply the drugs to us. And in fact, later company officials publicly denied ever agreeing to supply the drug. That was a huge disappointment for us, and we looked at other ways to move forward. The good news was that at least 80% of the Lucentis costs would be paid for because of the revised Medicare clinical trials policy. CMS and NIH leaders reinterpreted Medicare laws and the anti-kickback statute to allow another governmental entity to pay the copay. Now, previously, we had been thinking that the copay could not be paid for by anybody but the patients. And this all came out of this special fraud alert from the Office of the Inspector General. But the CMS and NIH officials said that because NEI was a governmental entity, this would be okay. So they agreed to pay the copay, which we thought would be affecting about 15% of our patients who didn't have supplemental insurance. So NEI said, do the best you can. This has been over a year that you've been trying to get this study started. We think you've done the best you can. So in early September, the DSMC approved the revised plan. And in late September, we had that investigators meeting. We're going to fast forward now about 3.5 years to the time when we've recruited all our patients and we have 1-year data on our total group of 1,200 patients. And here are the results. In red are the 2 treatment groups with bevacizumab or Avastin, and in blue is the Lucentis or ranibizumab group. And when the two drugs were compared, when both were given monthly, was 8.5 letters gained versus 8.0, or a half letter mean difference. And when the 2 drugs were given PRN as needed, it was 6.8 or 5 versus 5.9, or 0.9 letters difference. So the 2 drugs, when given in the same way, gave similar results, very similar results. And in fact, there were a number of other trials conducted, head-to-head trials of Avastin and Lucentis in other countries. And here are their results. And then in a meta-analysis, the final result was that the mean difference in visual acuity between the 2 drugs, when given according to the same dosing regimen, was about a half letter. So the results, those are the results for mean visual acuity. But now if we take a look at what happened to the actual visual acuity of the patients, you can see at 1 year, about 20% of the patients were seeing 20/12 to 20/20ths, 52% 20/25 to 20/40ths, 5% 22/100ths or less. And this was maintained through 2 years under our clinical trial protocol. If you remember the first slides I showed you where the median visual acuity at 5 years was 23/20ths, you can see how happy we were with the results at 5 years, where we have close to half of the patients seeing 20/40ths or better. Now, these admittedly are patients who were healthy enough to come back after 5 years. but it was about 80% of the living patients. Unfortunately, we now have up to 20% of the patients with 2200's vision or worse. Nonetheless, the anti-VEGF drugs have had a tremendous impact on blindness in the world. And as an example, here's some data from Denmark in which we see the incidence of blindness from AMD, the incidence of blindness from other causes. And you can see that after the introduction of the anti-VEGF agents, the incidence of blindness from AMD decreased by about half. Some of that may be due to just a time trend. There's a small decrease over time, 2006 to 2010. But clearly, decreasing by half the leading cause of blindness was really fantastic. So we were so worried about masking. How did the masking turn out? In the end, our clinic coordinators were unmasked to both dosing and drug. Our evaluators, the visual acuity examiners, and the OCT and photograph graders were all masked to both drug and dosing regimen. And the ophthalmologists were masked to the drug, and they were the ones managing the treatment decisions. The patients were initially masked, although their explanation of benefits would note ranibizumab if they were being treated with Lucentis, and have no drug listed if they were being treated with bevacizumab. So how did this work out? On every treatment form, we asked, did the ophthalmologist know which drug was being administered? And that only occurred in 0.2% of the treatments that the ophthalmologist said they knew. We take that with a grain of salt, but I do think that most of the time the ophthalmologist was masked. We asked the patients on their exit at 2 years, do you know what drug you were on? And if so, which one do you think it is? And about half the patients who were assigned to Lucentis said they knew and they were correct. About 25% of the patients assigned to Avastin said they knew and were correct. Only 3% of the people who said that they knew named the wrong drug. So those who said that they knew were actually correct. The other 50% and 75% with Avastin did not know. The copay caused us quite a bit of agitation, worry, and concern during the planning of the study. And our initial estimate was that 85% of patients would have insurance, and that when we took the other 15% and needed to pay the copay for the Lucentis, that it would cost about $700,000. As it turns out, we were way off on a number of assumptions. We had actually 42% of patients that required one or more copays, but the copays ranged from $5 to $500. So that in the end, it was closer to $800,000 that were used from NEI funds to pay the copay. What kind of impact was that? The total cost, directs and indirects for CATT, was about $26 million, and the copays came to 3% of the cost. How did it turn out for CMS? They ended up paying $18 million for the Lucentis in CATT and $0 for the Avastin. In our initial estimates, we had not allowed for missed visits and patients who died, so that actually decreased the cost. The co-payments remain a problem in clinical trials, and even the remuneration that is given, a lunch, paying parking, is still a murky area legally. The The Office of the Inspector General since 1990s has only 8 times given an advisory to people who have asked about whether paying the copay is allowable. And they have ruled favorably in all of those instances. But they also emphasize that these rulings do not necessarily apply to other very similar situations. So that the universities and practices that are worried about breaking the law with this anti-kickback regulation, they still have that hanging over their heads. And that there have been several pleas to make it explicit language in a law that says it's legal to pay a copay by the government. But none of these laws have been introduced. Also, 1 year after CATT started, we had been in touch with Senator Cole of Wisconsin. He was very interested in the CATT study, and he introduced the Cole Amendment into the Medicare Improvements Bill. And in that, Medicare, the Secretary of DHHS, was given the authority to make provisions for paying for alternative methods necessary to preserve the scientific validity of clinical trials, such as for masking and to ensure compliance, staying on the study drug in a particular study or design. Although that was enacted in 2008, it has not been invoked to date, to my knowledge. One good positive effect of our negotiations and our work in CATT is that when the Diabetic Retinopathy Clinical Research Network wanted to investigate the use of anti-VEGF agents for diabetic macular edema, Genentech and Regeneron, the maker of the aflibercept, the third anti-VEGF agent introduced, supplied drugs for those studies. Not the Avastin, but for the expensive drugs, the Lucentis and Eylea. Interestingly, for diabetic macular edema, which drug you use does matter, but only when the entry visual acuity is poor. When the visual acuity is relatively good, 20/40 or better, all 3 drugs work similarly. Also, as a follow-up, if we look at Medicare Part B spending for 2019, anti-VEGF drugs for ophthalmology are in the top 10 of all drugs in spending by Medicare. Eylea, aflibercept, is at the top with $2.9 billion per year being paid by Medicare for that drug in the treatment of 268,000 patients. Overall, there's over $5 billion being spent for over 600,000 patients per year. There are also some influences on the use of the 3 drugs that are available. The main reimbursement that goes back to the ophthalmologist is the cost of the drug plus 6% to cover overhead. And then there's some other complicated adjustments. Whoops, something's going a little fast there. The main part, though, is that the reimbursement is based on the cost of the drug. So that ophthalmologists are paid roughly $100 for injecting Eylea and Lucentis, and depending on which region of the country, anywhere from $9 to $31 for injecting Avastin, although the work involved in injecting any of those drugs is the same. In addition, both Regeneron and Genentech pay rebates to the physicians, the highest volume users, on the order of $50 to $100 per dose. So there's incentive to use the more, well, Eylea and Lucentis. So in summary, CATT is 15 years old, but it's brought up the comparison of drugs that are still quite relevant in the treatment of patients with neovascular AMD. I think that financing and study design are very much intertwined, something I never learned Biostatin 101, and that comparative effectiveness studies still face a number of challenges in implementation. Thank you.
Thank you, Maureen, very much. Let's see, if you stop sharing your screen, we can probably see each other a little better, maybe.
Do that since...
And if anyone has any questions for Maureen, I'm going to ask a couple or make a couple comments. If you would put them in the Q&A, I'll get to them in just a minute. So one question I have, first of all, I felt like I was watching like a true crimes documentary or something as you talked. And I also felt like what we weren't hearing, because a documentary is relatively dispassionate, I can only imagine the emotion of the study team at many of those twists and turns and frustration. And so anybody who's applied for grants and had grants stymied and has had a long path to funding, I'm sure is empathizing and thinking they got off easy compared to the CATT story.
Let me just say, it was a roller coaster, and I can definitely say that there were tears shed.
I'm sure there are tears and angry words, and I can only imagine. But I love that you have reconstructed the history. So when you asked me about this topic, I said, yeah, that sounds interesting, and you've exceeded all my very high expectations. So, I've been the IRB chair, biomedical IRB chair at Ohio State for some ungodly number of years. Did you tell the patients about the deal on the billing statement, or did you just leave it to them to figure it out?
We told the patients that we were not going to tell them which drug they were on. We told the patients that they may find out from billing documents which drug they were on. After that, we didn't say anything to them, and we always instructed our coordinators to talk about study drug and never bring up the words Avastin, Lucentis, ranibizumab, bevacizumab when talking to patients. Just study drug.
Study drug. Okay. Let's see. Question in the chat Q&A. So CATT masking wasn't perfect, which we saw with the number of patients, proportion of patients who knew what they were on and then were right. If follow-up rates are good in a study like this or others, do you think masking is worth it, or do you think masking is perhaps a little overemphasized or overrated?
Mm-hmm. So masking is wonderful when you can achieve it, because you don't have to worry about so many different influences that may be affecting treatment differences. Visual acuity measurement is pretty good. We have protocols, strict protocols, which sure takes some of the subjectivity out of it. But I think we all know, particularly with elderly patients, they have a high energy day and they think they should be doing really well. It could have an influence. So we are concerned. I always push for masking as hard as I can. We were relieved when the other clinical trials came in with such close treatment differences, because some of them were able to send out syringes with the drug in, and nobody knew what the patient was getting other than the coordinator of the central center. So as I said, I was relieved when the mass studies came in this close.
And your masking of your primary outcome measure was intact.
The examiners
Yeah.
were masked, and I believe that held up very well. It's the patient who could have
Said
affected
something.
that.
Yeah.
Although after a while, I don't know that either they could keep straight bevacizumab and ranibizumab.
There you go. On the topic of tears and angry words shed, someone asks, how many conversations did you have about just quitting the CATT study altogether? Or did you feel like, you know, God was on your side and you were doing something so noble that you were determined to do it no matter what?
So the people that the other leaders, Dan Martin, Stuart Fine, Glenn Jaffe, Juan Grunwald, never once said, we can't do this. I said, we can't do this. But there was a tremendous amount of enthusiasm that we should be able to do this trial, that it was important. And, you know, in the end, it's been very important in the United States. Until very recently, 60% of patients were being treated with Avastin. But what it did also was open up Avastin to the rest of the world, where they were not able to do these trials. And in middle-income countries where they can afford to give Avastin, but not Lucentis, they've been able to treat patients with neovascular AMD. So that's made it worth all those tears. And I am glad that my teammates had the perseverance to keep going.
So a word of advice, partner with people who are determined to do the work and at least maybe keep your moods of despair out of phase at the very least with your partners.
Yep.
Last question I've got here is if comparative effective trials writ large were left to the pharmaceutical companies, would they ever be done? Especially one like this with two products within a company that have such a large price differential.
So interestingly, the anti-VEGF agents, we keep getting a few more, and most of them have tested against monthly Lucentis, so they're doing active comparatives. Because the standard of care is once you get one drug that works, you can no longer not treat people. And so recently, the faricimab trials were announced. That's a Genentech drug for neovascular AMD, and they actually ran it against Regeneron's aflibercept because aflibercept is viewed to be the most powerful of the current drugs. So it's getting to be dicey, but they're running the trials.
Wow. Well, I'm just fascinated by this. Let me double check that I haven't left any questions on the table. I have not. So I know I join our audience and lots of connections to Ohio State Optometry, as I mentioned and you mentioned. And I have to tell you from Maureen's portfolio, she could have talked and given this lecture on a variety of topics in ophthalmology and optometry. This was perhaps the one most worthy of a telling, and you're a great storyteller, Maureen. You sort of weave all the pieces together. So we actually went ahead and sent Maureen her Hill medal ahead of time, so she has it with her. And so I know I'll hear from Dr. Hill and Lee. Let's see, there we go, and Lee. How proud they are. Maureen is our 7th Hill lecturer, and those of you who are wondering, Dr. and Mrs. Hill endowed this lectureship, and when they did so, it was a little bit before I became dean, and one of the things I remember thinking was, real programs have named lectureships, and they fill them with people in the field of great renown, with great stories to tell, and I feel like Dr. Maguire has fulfilled the goal of this lecture this year, in spite of the challenges of all being virtual, at an overused word, at an unprecedented level. So I want to thank you, Maureen. Let's see if I've got any other comments. Dr. Cindy Hill says, thank you for an excellent lecture. My parents and I enjoyed it greatly. So Maureen, thank you. Thank you for accepting the invitation under these challenging circumstances. And I'll tell you what, maybe we'll make a promise to invite you to Ohio State for a Hill lecture celebration when the world opens up and we can all travel again.
I would love it.
Okay, thank you. Thanks everybody for attending. The lecture is recorded and will be posted. So if you know of any faculty, graduate students, et cetera, who were unable to attend tonight, it will be available in a few days when Dave has done a little editing, and we'll post it on the website. So thanks very much. I saw we had a few people from around the country. Thanks everybody for spending part of your day with us today. Congratulations, Maureen. Thank you, Hills. Go Buckeyes. Thanks.
Thank
Bye.
you.